So, would like to thank all of you for coming on a Saturday morning. I'm delighted to share the stage with AIM at Melanoma Foundation and many esteemed colleagues from Roswell Park that are here to share a wealth of knowledge with all of you over the next several hours. I have no disclosures, and I will be starting with a primer for all of our patients. So the origins of melanoma stem from melanocytes, which are normal cells in our body that produce a dark pigment called melanin, so kind of shown here. And these cells are mostly found in the skin, but they can arise in many other areas of your body. They can arise in your eyes, in your ears, in your GI tract, in the mucous membranes of your mouth, of your genital regions, and of your nasal sinus passages. So, but predominantly, this is something that we see within the skin. And as with many other cancers, these cells can develop genetic mutations where their DNA effectively can be damaged and cause changes that make them cancerous, carcinogenic changes of the DNA. And this gives them the ability to grow and spread and become rather dangerous. In the case of melanoma, the DNA damage is often related to harmful ultraviolet radiation from the sun and tanning bed exposures as well. And here is one of the important pathways in the mutations that we pay attention to in melanoma, and specifically, as I'm sure many of you are familiar with, is a BRAF mutation is rather common that we do see in this process. And then just, in general terms, that's basically these mutations of the melanocytes with the suffix of "oma," just describing a cancer, means that you have a cancer of the melanocyte making a melanoma. When defining the most common cancers diagnosed in men and women throughout the US over the last year or so, melanoma does remain a relatively common diagnosis. Therefore, obviously important for us to continue to pay very close attention to it. But compared to some of the more common cancers, there is certainly a concerning observation that melanoma does tend to be continuing in terms of its diagnosis, whereas we are successfully reducing that diagnosis with some of the other common cancers. And this is concerning, obviously, as melanoma is not the most common cancer that starts from cells of the skin, but certainly most lethal and highly and has the potential to be very highly aggressive. So I presume many of you are familiar with the staging, but just in case anyone isn't, it's important to really understand it because this has major implications on how we treat it and obviously prognosis. So we utilize the TNM classification, which is a pretty standard approach, basically T for tumor, nodal involvement, or metastatic involvement. And so it's obviously much more complex with melanoma than just a simple stage 1, 2, 3, and 4. We have many subtypes, which were last updated in 2017, where we actually added a fourth subtype of stage 3. So obviously, this is very complicated and nuanced, but the reason is because there's dramatic changes in the survival, and so basically, each one of these have very different aggressive natures to it, and some of them can be much more aggressive than others, and these correlate to chances of survival. So, for instance, with patients with a very small melanoma, we would say like one of these T1A here, which would, with no other involvement anywhere, would be falling into a stage 1A category. And they have, those patients, followed over time, have a 98% 10-year survival, meaning that realistically, there is a good chance the majority of these patients have been cured by just the surgery alone. However, melanomas that have more aggressive characteristics with lymph node involvement or much deeper melanomas, and the depth is what's the most important in the staging here. So going down rather than going side to side, which I'm sure will be discussed shortly. So that has major implications in the staging, as we discussed, and that's all comes down to the process that we use here. And another important concept to pay attention to is basically that the biology really is important when it comes to the prognosis. And so, as you can see, and maybe it's a bit counterintuitive, that patients who have a stage 3A diagnosis actually appear to have improved chances of survival compared to those with 2B and 2C disease. And this may be counterintuitive at first, but it's effectively based on the biology. So someone with a very angry primary melanoma, even though they may not have any lymph node involvement, falling into one of the later stage 2 categories, do have worse outcomes based on just the biology of that disease, in the setting of if they had very minuscule lymph node involvement and maybe a more less aggressive primary melanoma for someone falling into the stage 3A category. Now, one of the encouraging aspects of the curves I just showed is that those data are going back to 1998, which was well before our current therapies like immunotherapy, which many of you are familiar with. And this is rather important because the treatments before the immunotherapies were developed, the survival was rather grim, and this was a long-term observation. And so once the development of immunotherapies came about into the realm of melanoma therapies, there was certainly a dramatic change in survivals, and that's a very important thing to pay attention to, and has now been very well documented. So basically, this table here was showing that there's a very impressive and consistent decrease in the annual percent changes of the survival rates for folks with melanomas. We're for the first time in 4 decades where we can significantly decrease the rates of death starting after these, the major developments of this. So obviously we considered that a huge deal, and obviously celebrate it. And there's been documentaries made on it with relatively solid ratings. So to understand the immunotherapy that I just mentioned, the checkpoint inhibitors, as we call them, it has complex machinery that allows to differentiate between healthy cells and not healthy cells in the body. This is a normal process for your immune system to be conducting. And typically, the immune system has mechanisms that allow it to recognize cells that are not supposed to be there and cause an immune response that can attack them and take care of them. So one way the immune system, and this is one way that the immune system is kept in check, is by expressing certain proteins that prevent the immune system from attacking what we would say your normal cells. So by keeping your immune system in check, the drugs that would block those proteins we refer to as immune checkpoint inhibitors, also known as immunotherapy. And effectively what happens is, so that if the cancer cells are expressing these proteins, then what happens is once you're blocking them with certain agents, which we call the immunotherapies, and many of you are familiar with these specific ones, they allow the immune system to effectively become more activated, recognizing the cancer cells, many other complex mechanisms that I certainly do not have the time to elaborate on, but effectively making the immune system have a more robust response to the cancer that's been developing. Now, obviously, the immunotherapies that we're seeing the responses are in many patients is certainly exciting. The reduction in mortality is obviously a massive benefit that I will elaborate in more detail shortly. But it's important kind of to, as I'm describing the mechanism of the drugs, is to understand the mechanism of the side effects, which is certainly one of the challenges that we face with these agents. So in broad brushstrokes, the drugs are effectively causing inflammation within the cancer cells. But unfortunately, when the immune system becomes activated by these immunotherapies, you can also trigger the immune system to cause an inflammatory response in part of the body that was not intended. And so the word itis means inflammation. So as you can see here, this is a description of all the various side effects that we observe with these immunotherapies. And you can see the word itis after pretty much any organ. And that's an easy way to wrap your mind around the side effect profile that we can see from these agents. And it's because once again, our normal cells do have these checkpoints as well. And so sometimes there can be this cross communication, and we do observe this. You may or may not have read your notes and that we document in clinic. And if you do, you may see that we're using these grades, and the grades are based off of a standardized approach that's been well established, where we are able to have clearly defined criteria for basically any symptom that you may be developing that we suspect is related to the immunotherapies. So grade 0 means that it's really not interfering much at all. It's almost not existent. Grade 1 means it's kind of burdensome and annoying, but it's not really causing major clinical relevance. Grade 2 is when it is becoming an issue and may actually be causing decrease in your quality of life, and we may need to intervene depending on the organ that's developing the inflammation. And things accelerate very quickly after that. So we consider severe grade 3 and higher. So severe is basically we do need to act on this. We do typically would require hospitalization or some sort of major intervention. For immunotherapy in particular, a gold standard would be steroids. Many of you may have received the steroids for various side effects. And typically it's when we're falling, just classically, it's when we're falling into the stage 3 category where we would pull the trigger to really say that it's time to start higher doses of steroids. And then, as I said, it accelerates quickly. So stage 4 or grade 4 is when you actually have severe enough side effects where you may need to be in the ICU or it could be considered life-threatening. And grade 5 is it was fatal. The side effect is what was presumed to have been a fatal event. So that's important to wrap your mind around, obviously. So when it comes to the various immunotherapies that we utilize, these are some of the rates that we observe for various side effects. So that once again, as you'll now see in my slides and then future slides as well, grade 3 plus TRAEs is meaning just severe side effects from the immunotherapy. And then we separate out the endocrine toxicities, and what that is side effects from your hormone secreting glands, your endocrine glands. Those have a bit of a different trajectory than some of the other immunotherapy related toxicities. So and they tend to be more chronic, meaning they don't always resolve, whereas many of the other side effects can be resolved, usually with steroids at various doses. So as you can see, the single immunotherapies by themselves tend to have a lower risk of side effects, major side effects, compared to when we have to recommend utilizing combinations of these agents. And it's important to recognize that, as I mentioned before, the immunotherapies are activating your own immune system. So it's not the drug necessarily that's killing the cancer cell, it's your own immune system. And in that same idea, it's also the drugs that are causing inflammation that's making the side effects. So unlike some other drugs where you may get side effects right after starting a treatment, the immunotherapy does tend to take time to really see these side effects become active because your immune system gets turned on first and then the inflammation comes. So here's a chart of various side effects that we observe traditionally with the immunotherapies. And as you can see, it can take several weeks and sometimes much longer that we will actually see certain side effects develop. So unfortunately, I don't think we're ever completely safely out of the window of side effects, especially while you are on active therapy. And once again, these endocrine hormone secreting gland side effects can really stay predominant for quite a long time and show up much later than most of the others. So just a quick summary here, the low grade in adverse events typically actually are a reflection of your immune system becoming activated, some much more so than others. So it is a reflection of your immune system being activated, and when it's been observed, it tends to suggest that there are improved responses and therefore survivals. The more severe ones can be life-threatening, and therefore that's why we keep extremely close eyes on our patients while they're on their therapies. Typically, when the severe side effects occur, the high doses of steroids are required to help get that under control. And obviously, we are working hard to perform additional research that can try and predict patients that may be developing these side effects, as well as better targets to actively focus on the organ that's becoming inflamed. And for the rest of the time I have, I'm going to pivot briefly to just discuss some of the management and the patients that we would consider high risk in the stage 2 and 3 categories. So the reason I'll be discussing this is because usually if you have one of those very early stage melanomas, then effectively the surgery is considered curative. I work in the medical oncology department, so I do not get the luxury to get to see many of these patients. So it's usually when there's much more serious consequences that they would be coming to our clinic. And so this is going to be a quick timeline of how we approach treating that. So basically, back in 2015, so we're looking at basically patients who have a diagnosis of stage 3 and patients with more advanced stage 2. So a timeline of this is 2015. Basically, ipilimumab was one of the first immunotherapies that we were utilizing in the melanoma space to investigate the survival benefits. And so this particular trial was looking at patients with stage 3A, B, and C disease. Now, this was before the update, so there was no 3D. So that makes a lot of our data that we utilize to show patients a little bit difficult, because things obviously are always subject to change when it comes to staging and other aspects of things. But overall, obviously, I think it became very clear that some sort of immunotherapy, rather than just observation after surgery, has what we call an improvement in recurrence-free survival. And I think it's important that I take a moment to explain what that means. So recurrence-free survival is basically you are still alive and the cancer has not come back. That's kind of a simple way to think about it. And it needs to be both of those things. So truly no recurrence coming back, so recurrence-free survival. And this is different than some of the graphs you'll see later where we discuss overall survival. And the reason why in what I'm talking about right now, I'm not talking about overall survival, is that a lot of folks who have their melanoma removed surgically may be cured. So it's very difficult to statistically prove that there's going to be a true overall survival benefit. But what is important and what's more tangibly measurable is whether or not the cancer comes back within the time frame that we're doing these trials. So I know I won't have much time to go over all of the details of this, so it's hard for me to give you all the exact numbers, but basically these studies have been done long ago, and therefore we have long-term follow-up that is observing the reduction in the risk of the cancers coming back with patients who did undergo treatment after the surgeries versus those who did not. Now this one was one of the more historical ones, because one thing we've discovered is that ipilimumab by itself realistically does not have nearly as effective of a response as the checkpoints that target what we call PD-1, which is a different checkpoint that I'll show in a second. But also high doses of ipilimumab by itself really can be extremely toxic. So it really has fallen out of favor. So in 2017, then there was a trial that was done that looked at Ipi, as I just mentioned, versus Nivo. So they really compared the two. And this is one of the trials that truly set nivolumab apart from Ipi and the PD-1 agents. And so many of you have probably seen the word Ipi, been treated with Ipi, that sort of thing. And this is one of the many trials to show why we don't typically use Ipi by itself. It's usually something that you would see in a combination. Whereas you will see things like nivolumab and pembrolizumab utilized commonly by itself. And so basically the endpoint of these studies with these patients were recurrence-free survival going out to 4 years. And once again, utilizing the Nivo was significantly better than the Ipi. On to 2018, this was patients with stage 3A, B, and C that had their melanoma removed. This one was looking at placebo rather than any additional treatment as compared to this one. So this was utilizing pembrolizumab versus just observation after surgery. And obviously there was once again, appreciable difference that treatment after surgery for these folks it was important in terms of reducing the risk of the cancer coming back. These lines may have even been further spaced out, meaning even more impressive. However, the trial was made in such a way, because of the fact that it was a placebo, that there was crossover allowed, meaning that if the cancer did come back, you were allowed to start on therapy. And running out of time, so I will go a little bit quicker for the rest of these. So I mentioned the BRAF mutation earlier. It's a mutation that is commonly observed in many patients with melanoma, and if they have that mutation, they are eligible for what we call targeted therapy, which is different than immunotherapy. It's a pill that truly targets a specific mutation. And so for patients who have a melanoma removed in the stage 3 categories, who have the BRAF mutation positivity, this was studied in a trial where they also observed that utilizing these drugs significantly reduced the risk of the cancer coming back compared to a placebo, meaning just observation after the surgery. Sorry. So I will cruise through the rest. So then the patients with the high-risk stage 2 patients with high-risk stage 2, obviously there was not, everything I just discussed was in the stage 3 realm. So later on, 2021 is when we started to look at the patients who have a high-risk stage 2 diagnosis as well. And so these are the data that came out, and obviously it was a bit longer because they first focused on the more high risk in terms of stage 3, and then obviously they moved their focus to high-risk stage 2. So this came later. And once again, the recurrence-free survival was appreciable through the utilization of anti-PD-1 checkpoint inhibitors, meaning pembrolizumab, and as well as nivolumab. And this is the chart that showed that in Checkmate 76K. It's important to recognize that the side effects of these drugs were significant, were notable and relatively high in some of the trials more than others, between 10 to 15% in many of them. And then, as I mentioned before, some of you have heard or been treated with ipi and nivo together, ipilimumab and nivolumab together. This was studied in the stage 3 population, and really there was after surgery, getting things removed, and there was really not much of an appreciable difference in that recurrence-free survival. So this is one of the main trials that ultimately did guide us to not recommend the combination in the setting of having your melanoma removed in a stage 3 category. So quick summary of what I just described there. Stage 1, early stage melanomas can be considered curative with surgery alone, which will be discussed shortly. Stage 2, B, and C is considered higher risk, and there is an appropriate discussion to be had about the potential benefits of having therapy after surgery, which is that the term adjuvant means therapy after surgery. And in the stage 3 categories, what's considered the highest risk would be B, C, and D, and it's important to have conversations about the benefits of treatment after surgery for that diagnosis. Obviously, the discussion is important because the side effects are known. And then very briefly is that there is new data that has come out in what we call neoadjuvant, which is when we treat with immunotherapy before surgery. And this has been an exciting development over the past few years. And it kind of goes with the science that I discussed, is that if the immunotherapy is allowing your own immune system to recognize the cancer cells, then if we're cutting out the cancer cells first and then treating you, your immune system may not be able to recognize the cancer as well as if we left the cancer in the body. And so this is where the neoadjuvant approach kind of makes sense scientifically. And as you can see, there's increased cells that are able to kind of recognize the cancer cells in the neoadjuvant arms. And so do not have time to explain the neoadjuvant approach in much detail, but I will just say that there's very encouraging findings where if we are treating our patients with clinically detected nodal involvement, lymph nodes are involved, we confirmed there's melanoma, and it's large enough where we feel as though we can clinically detect it, then patients are basically being offered an individualized treatment approach where you have 2 doses of combination immunotherapy, then you have the node removed, and then based on your own personal response, determines your next steps in terms of treatment and has rather significant implications in the outcomes, which I can discuss in person if anyone wants to talk more later. So my conclusions, that melanoma exhibits many aggressive features compared to more common skin cancers, which may be fatal. Melanoma at early diagnoses can be cured with surgery, and therefore dedicated efforts in early detection and routine UV protection is vital. High-risk melanoma, systemic therapy discussions are appropriate after surgery, but should be discussed, with a clinician who understands the risks and benefits to truly help you understand what kind of benefits you're achieving and the risks that you would have with those therapies. And immunotherapy has dramatically improved the outcomes for patients with melanoma, but carries a risk of severe and/or chronic side effects. And research is ongoing to improve the success rates of all of these treatments, and particularly in patients who may not be responding well to the therapies that we do have available to us, as well as just truly are not tolerating the therapies that we have offering. And we are working very hard on that here, and you'll probably hear more about that shortly. And that is all I have. I'm sorry that I went 5 minutes over.